I'd like to present a paper on the restoration of glenoid joint line with bone grafting in cases with reverse shoulder arthroplasty for significant bone loss. I'd really like to thank my co-authors for this study. These are our disclosures. These are some of the cases or the kind of bone defects which I've encountered in revision of reverse shoulder replacement. In this patient, the coracoid base is there, the scapula, the lateral pillar is just pencil thin, and there's a huge deep glenoid defect which is almost 4 centimeters deep. What do you do when you've got a challenging situation like this on your hands? So I am a big believer in allograft because I want to restore the bone in every operation I perform a reverse shoulder replacement on. I'm not a big believer in putting custom implants. Personally, it's dealer's choice. And in a case like this, I do a figure of 7 graft as taught to be by my mentor, Dr. Seebauer. And this is the kind of a stability you get in a defect which when you start, you think is not achievable to be reconstructed. So you do a case like this and you're fairly happy with yourself and that the joint line's been restored, the bone's been grafted, and the patient comes back to you at 1 year and has a reasonable clinical outcome. But I think the critical bit in this to analyze and to rationalize is that how good are we as surgeons when we recreate these defects to getting the joint line back. And based on some of the work which I've done during my master's, is we figured out that the joint line is approximately 8 millimeters from the base of the coracoid in a female and 1 centimeter in a male. The analogy to this would be on a soccer field. You cannot have a South American meeting without not having a soccer field. So this, I would say, is where the zero line is or the joint line is. This is lateralization. So the concept of restoration versus lateralization is really important. If you have a patient with a glenoid bone defect, this is restoration of the joint line. And this is lateralization of the joint line. So these two concepts, I believe, are often used interchangeably in literature, and we sometimes say that, oh, we're over-lateralizing and we're medializing, etc., etc. But no one actually talks about, are we restoring the joint line? Are we bringing it back to this zero line where we need to get the joint back to? So we decided to do a study where we looked at 106 of my reverse shoulder replacements, and we found 26 of these which had quite significant or severe defects which were bone grafted. 21 of these patients were available because 3 had a single stage revision which were excluded from this study. So we had 20 primaries and 1 revision. Anyone which had a 1-stage revision because we could not CT scan them or had incomplete imaging were removed. These were the indications for surgery, predominant being osteoarthritis. We classified the defects based on our paper, which classifies defects as centric and eccentric defects for such severe defects. And in the revision situation, we need a 3D volumetric assessment of bone defect morphology. So based on this, we figured out that majority of the defects in our classification were moderate to large to massive bone defects. Only 14% were small bone defects. We looked at the preoperative CT. Then we looked at the postoperative CT of these patients. And we merged the preoperative and postoperative CTs. Then we were able to segment the metal wear out of the postoperative CT and then mirror it onto the pre-op. And this gave us the estimation of the joint line restoration and the glenoid graft that we had used in these patients. And this is what the model looked like, and it was very reassuring to see that these bone grafts had completely incorporated between the pre-op and the post-op when we merged the post-op, which is yellow, to the pre-op. Then we went about analyzing how accurate we were in restoration of this joint line. So we looked at a whole bunch of parameters, which was the base of the coracoid, and another point was taken at the midpoint of the base of the coracoid, or the anterolateral aspect of the coracoid. Then we marked the GC, which is the center of the glenoid, and a line passing through the deepest part of the defect and the part of the base plate. Based on these points, we were able to calculate the distance between CA and CB, and to the medialmost point of the defect to CB, and the base of the base plate, or the joint line which we restored to the CA and CB. Our analysis showed that most of the defects had significant medialization, with one defect going up to 18 millimeters of medialization of the joint line. When we look at the medialization from the center of the glenoid, this was a bit less because sometimes the defects were more eccentric. So measurement of the bone defects from a center point in the glenoid is often not reliable because a lot of defects are eccentric defects. But even then, we had a mean medialization of 6 millimeters here. So this is where the majority of our preoperative defects were. They were quite medialized. So how good were we in restoring the joint line? To our surprise, and much to my happiness actually, I was able to reconstruct the joint line back to 9 millimeters from the base of the coracoid. Thus, we were satisfactorily able to restore the joint line to its anatomical starting point. When we looked at it from the base of the coracoid, this was in some cases a 15 millimeter restoration. All the cases in our subgroup, the graft had completely incorporated because we followed the 50% rule, which we defined in one of our previous publications. So this is a case which had an anterior shoulder dislocation in the elderly. And this was the bone defect after 6 weeks of a lock dislocation. I performed a figure 7 graft for this patient. This is the graft, as you can see, intraoperatively, and then this is the post-operative imaging of that graft, completely incorporated with a CT scan performed a year down the track. It's very reassuring to see these grafts heal up. Our graft thickness on an average was around 12 millimeters, but this extended from 12 to 17 millimeters. So to summarize, we were able to reliably demonstrate between the preoperative CT scan and the postoperative CT scan that we were able to restore the glenoid joint line after grafting.